blood supply is plethoric. It is very difficult to devascularize the rectum. There's blood that comes from above, from the inferior mesenteric. We call it the superior hemorrhoidal. We have a vessel that is a little bit more unpredictable, called the middle hemorrhoidal, and then we have the inferior hemorrhoidal. So it is very, very difficult to devascularize the rectum during the course of normal surgery. One of the aspects of the anatomy of the anus and rectum is the hemorrhoidal vessels. These veins run in the lining of the bowel, and also the inferior hemorrhoidals come through the muscle, and they fill these veins. Now these veins, with increased intra-abdominal pressure, examples would be people who tend to be constipated, men who have difficulty urinating and have to strain a lot. The process of pregnancy increases the intra-abdominal pressure. Patients who have ascites have increased abdominal pressure. All of those increase the pressure in the veins and cause them to enlarge. Although we refer to basically three major venous complexes, there are actually a lot of veins down here. And so I tell people we really can't eliminate your hemorrhoids. We can get rid of those large ones that are symptomatic. But if you have predisposing conditions, they're likely to come back at a later time. If the veins are just on the outside where we can see them, we call that an external hemorrhoid. If the veins are up inside where we can't see them as easily without a scope or something, we call those internal hemorrhoids. And those internal hemorrhoids have the opportunity to get large and actually slide to the outside, in which we call it a prolapsing or sliding hemorrhoid. Here might be a picture of what you'd see if you were looking at hemorrhoids from below. And the feature of this looks circumferential, and it is, but the feature of these radial folds, which suggests they're hemorrhoids as opposed to another process I'll tell you later. Here's another example of sliding mucosa or hemorrhoids, again with the radial folds. Here's another example. Now, this patient might very well come in and say, I have seepage and itching, a lot of itching. Itching often comes from moisture. And you see this mucosa that's slid to the outside, and it tends just to stay there. And you can push it back up, it'll come back out again. There are also some probably old hemorrhoids, we call these skin tags on the outside, that are difficult to clean and often responsible for itching. These little crevices and so on are difficult to get at. But this would be a hemorrhoid that's sort of stuck on the outside or lining of the bowel. Now, we talked about the anatomy and the unique anatomy of the puborectalis muscle and the fact that it is not circumferential but leaves sort of a weak spot in the front and the back. And we think that that's responsible, at least in part, for fissures. We think another aspect of the fissure is that this muscle overall, this muscle complex, is high, that is very strong. So people with fissures tend to have very high anal pressures, and they tend to have this defect or this little cut. Now remember, it's in the skin. This is not in the rectum. This isn't up inside. This is in the skin that's inside the anus. You can't see it in the so-called anoderm. Those tend to occur in the midline. 90% of them are in the posterior midline, and about 10% of them are in the anterior midline. And the problem with them is they erode and they get deep to the point that they expose the muscle. And these patients come in with bleeding and pain, particularly pain with defecation. Hemorrhoids don't hurt. Well, they hurt if they get thrombosed. Sometimes even the one that was sliding to the outside wouldn't hurt. So if people come in with anal pain, it's pretty unusual that it's due to hemorrhoids unless they also say, I got a lump there. But if they come in with pain with bowel movements, this would be your first guess that it's a little cut, we call it a fissure, that it's eroded its way down to the muscle and is causing pain with defecation. Remember we talked about the anatomic feature of anal glands, and we see a little gland. Those glands come off the crypts, and the gland itself is actually in the intermuscular groove between the internal and external sphincter. For reasons that we don't understand, doesn't seem to be related to hygiene or anything, they can become infected. And when you have an expanding mass anywhere in the body, and here it's in a very confined space, it causes pain. As that grows, it presents to the outside actually, and it looks like a reddened, indurated, tender area, an infected abscess, which we often drain. Call that perianal abscess. And that abscess may result in a communication between that gland and the outside where we drained it. And that's called a fistula, an anal fistula. So we see those with some frequency as well. They can become quite complicated. Because of these anatomic spaces and grooves, they can go north, they can go south, or they can go laterally and create these various tracts and tunnels. The vast majority are like this, or perhaps like this. This represents less than 5% of the anal fistulas. So most of them are relatively simple. Another problem is that the rectum itself is supposed to be tied to the sacrum, but some people, perhaps because the sacrum is a little straighter than in other people, it doesn't seem to sit there very well, and it tends to slide to the outside. And that's called a rectal prolapse or procedentia. You know, we'll probably hear about the same sort of problems with the uterus doing that, and the bladder can do that and so on, but in any event, this is the rectal problem. It's not tethered to the sacrum like it normally should be, so it slides in and out. Now, when you see this, the muscles are fine. I mean, they get stretched, and over the course of time, they can become like elastic that's been overstretched if it's out too much, and they can become weakened. They can also become denervated because as this slides down like this, it pulls on the nerves, and when it pulls on the nerves, you get a traction neuropathy. But anyway, this is a condition we see with some frequency, more common in females than males. Again, probably because the pelvic support is not quite as great. You characterize that by seeing that bowel sticking out, but now the rings are circumferential from an anatomic standpoint. They're not radial, like we saw in the earlier picture. And here's an example of a relatively small one. Here's one that's a little bit larger, and I don't know how well they project, but they're radial. Again, the muscles are stretched, but they're in place for the most part. And then finally, we have a weakening sometimes that it can occur between the rectal and the vaginal wall, and that weakening can cause a bulging of the rectum into the vagina, and we call that a rectocele. And this is sort of our bridge between our two groups today, in that both of us want to fix that. This characterizes itself usually with some form of constipation, but I'm going to describe it as obstipation. In other words, they often feel like they get the stool down there, but they can't get it out. And if a lady places a finger or a thumb or something to support that wall, that redirects the stool to come out the right way rather than trying to go out through the vagina, and they're able to pass it a little bit better. If you look at it from an x-ray standpoint, here's one example of it bulging in. Here's another example bulging the other way into the vagina, so you see a substantial push off of that. And then just another example of it. And here we see, as my next to final slide, the sort of falling apart of the entire perineal floor and rectum, where you see the rectocele here coming out, perhaps the cystocele, and we see the rectum coming out. And so we see the pelvic anatomy is totally destroyed or distorted, and obviously somebody has to fix that. Just as a remembrance of everything about this weekend, it's sort of a special time. Thank you, and I'll look forward to answering questions.